And for those of you joining me regularly, you know the order of events. And for our new listeners, let me introduce myself. My name is Neeti, and I'm the owner of Back to Basics Functional Nutrition Practice here in Dallas, Texas. The purpose of doing this lives every week is to invite a fellow practitioner from my integrative, holistic, and functional world and share non-traditional ways which is not known mainstream. And if you are a woman and you struggle with menstrual cramps, infertility, chronic pelvic pain, weird periods, weird menstrual hormone symptoms, please listen up, because my special guest today is Dr. Tanvi Bhatt Maharaja. She is a pelvic health physical therapist. She is also board certified in orthopedic physical therapy and is also a pregnancy and postpartum corrective exercise specialist. She practices physiotherapy full time at Signature Healthcare in Brockton, Massachusetts. I've known Tanvi for many decades. I knew her as an inquisitive junior back in my physiotherapy school, and now I know her as a full-time physical therapist who has so many accolades and who keeps getting so many good reviews from her clients and is an awesome physical therapist. And so, without further ado, let me welcome Tanvi. Welcome, Tanvi.
Hi, Niti. It's good to be back in touch with you. Thank you for the introduction. And let me just start off with saying that I have seen other guests on your show, and I'm so impressed by all the knowledge that they have shared. And I keep going back to some of your recordings. They're just so wonderful. Thank you.
Awesome, awesome. I'm glad. And together we are going to share some more wellness and insights into this complex topic of endometriosis, which we know it is many people are misguided, it is misdiagnosed, and I know I'm looking forward to you throwing light on that. But before we jump into the topic, why don't you begin by telling our listeners your story, and so that we know your background and your accolades and why you practice what you do.
So I had a private practice in India, and I moved to USA in 2015. I started off practicing here in Brockton, and all my years of practice wanted me to keep improving my education so I can serve my patients better, which is why I further studied for the board specialty in orthopedics. And then I also did a lot of work on the spine. So I was seeing, as a result of the specialty and doing more spine work, I was seeing more and more spine patients, and they went back to the physician and said, okay, she's doing good work, so send more spine patients. And ultimately I was like seeing so many spines at the end of the day. And the more spines I saw, the more I realized that there is something that's missing here. Like we are orthopedic physical therapists, so we do everything from the head to the lumbar spine, and we do the hips, and we do all the lower extremities and the arms. But there are things that are happening in the pelvis that are causing some characteristics of back pain, which we are not educated upon in our regular physical therapy practice. So the more spine patients I saw, the more I realized that there is a missing piece of the puzzle here. And that drew me into the world of pelvic floor physical therapy. And once I got in, it was just like an eye-opener. It was a whole new world. It changed the way I saw patients. And I had this sweet spot where I was seeing spine patients from a pelvic floor perspective, and I was seeing pelvic floor patients from an orthopedic perspective. And it just like gelled so beautifully. It's amazing to see patients as a whole. It's not like a hip or a spine. It's a person in front of you, and everything is connected. So it's just amazing to, kind of, like I said, see the world through a different lens.
Oh, nice. Love that. Love that. I love when we can connect the dots and it's just like an aha moment, right? Like,
exactly.
Whoa, why didn't I think of that earlier, right?
Yeah, absolutely.
Awesome, awesome. So I am sure your patients are benefiting so much because you have that broad spectrum of knowledge. So what exactly is pelvic floor PT?
So pelvic floor physical therapy is one of well, I might be biased here, but it's one of the coolest specialties in physical therapy. And I actually got a model of the pelvis, so we can kind of look. So when we talk about pelvic floor physical therapy, you want to think everything from below the ribs up to the knees. That whole area, anything going on in that area, you'll probably benefit from pelvic floor physical therapy. Okay, now, if you look at the pelvic floor, we have all these organ systems inside of the bony pelvis. We have the rectum at the back, we have the uterus and the vagina, and the bladder and the urethra in the front. And this whole complex system surrounded by blood vessels and nerves and fascia and ligaments and ovaries. Anything that goes wrong in any of the systems affects the entire pelvic floor. So we see a lot of GI symptoms. We see a lot of, we see a lot of even like hip and spine symptoms, which are originating from the pelvis. You see a lot of symptoms that are affecting the colorectal system. You see a lot of pain with sexual intercourse, those kind of symptoms like dyspareunia. You see incontinence, which is a big one.
Right.
And I also just wanted to take this opportunity to say that when we think pelvic floor physical therapy, one of the misunderstandings is that it's for women, but we also have pelvic floor physical therapy for men. So we do treat men and women. And, it's not doing Kegels. So it's not like, what do? We just do Kegels. No. One of the many, many, many things that we do. And even if you are doing Kegels, there's a chance that you're doing it wrong, or you're not layering it, you're not progressing it, or you might be doing the opposite of what you're supposed to do.
Correct.
Or Kegel is contraindicated for you. You shouldn't be doing Kegels with your condition. So don't just do Kegels because you read it on Google.
Right.
Pelvic floor therapist can help you. So yes, that's pelvic floor physical therapy. It's a very complex system, and it's abdomen, pelvis, spine, hips, all of that together.
Wow. Sure thing. And like you said, that it is complex because there are so many blood vessels, so many nerve endings, so many things going on. So if you just go to Google and just looking for a quick fix, that might not always be the answer. So a pelvic floor physical therapist would know so much more and would be able to help you.
Yeah, it's amazing how many women come to me and say, "Oh, I've been doing Kegels," and I say, "Okay, show me what you've been doing." And they're doing the exact opposite thing, and of course they're getting worse. So like, okay, let's start over.
Correct. Yes, exactly. And I know so many people do have so many symptoms that they are carrying, and I know some of them, they don't even know that they have endometriosis, right? So why don't you throw a little bit more light on this complex topic? And I know the prevalence is so much, like it's almost affects like the stats show like 10% of the women. But so many more have chronic pelvic pain, right? It might not always be endometriosis, but they do have so much chronic pelvic pain, and it leads to so many range of symptoms like painful periods and painful intercourse and just hormonal issues, and the list can just go on and on. Yep. So why don't you throw a bit light on the pathology of what happens, what are some reasons, and basically just in that area so that we understand it more.
Absolutely. And this is one of the conditions I'm very passionate about, largely because it is very poorly diagnosed and treated even more poorly. So we need to shed more light on this. And the more we talk about it, the more education people get about it, they'll be better off. So endometriosis is a condition that is inflammatory in nature. It's usually in the pelvis, but it is not necessarily confined to the pelvis. We have found endometrial lesions as high up as in the GI system, around your intestine, in the stomach. It can go up to your ribs, to your diaphragm, which is your breathing muscle. They've even found endotissue in the brain and in the lower limbs. So endotissue can be anywhere in your body, although pelvis and abdomen are the most common areas. So it's a result of tissue migration at birth, right? So the term endometriosis is a misnomer. When we think endometriosis, we think endometrial tissue, which is the lining of the inside of the uterus.
Right.
So a lot of people think that it is this tissue that migrates outwards. That is not so. Endometrial tissue that is in the uterus has similar characteristics histologically to the endometriosis disease tissue that we find elsewhere around the body.
Okay.
But just because they share some common histological characteristics does not mean that it is the same tissue.
Oh.
Okay. This tissue is laid down at birth embryologically. So most people are born with tissue that is outside of the endometrium in different places. And when these individuals hit puberty and become hormonally more active, the tissue that is endometrial tissue outside of the body reacts to the hormones. And then that's when, because there's a lot of inflammation around it, it becomes a pain-generating tissue. And over time, it leads to adhesions and scarring, which restrict tissue mobility, and the pain kind of just gets worse over time. An interesting thing about endometriosis is because a lot of people believe that it is from the uterus and then goes out, they think that taking the uterus out, doing a hysterectomy will solve the problem. It does not solve the problem at all, because the tissue that's elsewhere is still reactive to your hormones. Right. In fact, it produces its own estrogen and progesterone. So if you take a slice of endometrial tissue and you stick it under the microscope, it will not only produce its own estrogen and progesterone, it will also develop its own blood vessels, its own nervous system. So it's kind of a beast that just keeps growing and growing. So just taking the uterus out or even taking the ovaries out is not the solution. And we see so many young women, at a very, very young age, who have their organs taken out and they're still in pain because there's endometrial tissue elsewhere that has not been looked at. So this is very sad and actually frustrating.
Correct. Yeah, because once the uterus is removed and or the ovaries are removed, that just brings another host of problems which are not thought of or not looked into, right?
Exactly. Yeah. So this is the time when we are building bone tissue in the body, right? So you're banking bone tissue at this young age, and then when you hit menopause, that's when all this bone tissue kind of helps us. If you put young women in the menopausal state at this young age, they have no time to build that bone tissue, and they have premature osteoporosis, not to mention that they cannot have kids, and it just messes everything up so badly. You're putting them in menopause in their 20s and 30s. It's just awful.
Oh my God, that is sad, truly. And like you said, genetic predisposition is probably how the misery starts, right? So, but what can we do to relieve the pain? What do we have under control, or what is it that you can do to help them with managing the pain?
Right. So the problem with endometriosis is because it is poorly understood. We don't know the exact pathogenesis, right? So we don't know what are the exact things that cause it. We do have some idea about some general indicators or contributors. We know that, of course, there's like an embryological component there. That's a hormonal component. It's a genetic trait. So if moms and daughters in the same family kind of seem to have it together, so we know that genetically it is kind of carried over the generations. We know that because it's an autoimmune disease, it's kind of inflammatory in nature. So inflammation is a big component to it. There's also other things, like there's an HLA antigen that kind of tests, if you test for it, if an HLA is on a particular site, then you might have it. Or there's a CA125 that is usually tested for ovarian cancer. That is also one of the things you can test for, that we know that is connected to endometriosis. So now we know all these things, but treatment is very definitive, right? So it's like if you have a thorn stuck in your foot and it's hurting, right? And then you have all this pain all around the area. No matter what I do to the area around it, I cannot really cure you until I take that thorn out, right? I can massage your foot all you want and give you painkillers or throw hormonal medication at you, but if I do not take the thorn out, it's still going to hurt. And it's going to hurt more over time, because the pain generation is just going to get worse. Your brain is going to get sensitized to it, and it's a chronic pain condition. So similar with endometriosis, the only surefire way to cure it is to do an excision surgery, where you go in and you take the tissue out.
Okay.
Now, before we go there, I want to talk about the diagnosis. So
Okay.
when we talk about diagnosing endo, there's multiple ways, but the gold standard is laparoscopic excision with histopathology. So you take out the tissue from different
Okay.
parts of the body and you send it for biopsy, and then that's the only way. Can you do an ultrasound? Sure. Can you do an MRI? Sure. Clinically, we get some idea from the patient's history, from the exam, but diagnostic laparoscopy with histopathology is the only way we can really be sure that that's done.
Ah, I see. Okay, gotcha. And so I understand that, but what is the role of a pelvic floor physical therapist in all of in diagnosis, and how do you help them?
Right. So I think of the role of pelvic floor physical therapy in three different subsets. There's three different subsets of people that we can help with.
Okay.
The first is the diagnostic element. So when someone has endo, usually it's not endo alone, because endometrial tissue is within different systems of the body. They also might have a painful bladder syndrome condition, or what is commonly diagnosed as interstitial cystitis. It is not technically interstitial cystitis because they may not have the Hunner's lesions, but it is a painful bladder syndrome. They might have IBS kind of symptoms like bloating and cramping. They might also have things like pain with sexual intercourse, which is like a deep thrusting pain, not just a superficial pain. They also have pain with defecation, which means when they have a bowel movement, it's painful. And the biggest characteristic is pain during their periods. Endo pain causes painful periods, but so do a lot of other conditions. But when you have endometriosis, the painful period starts a day or two before your period actually begins. It's not the day of your periods. And that's a very distinguishing feature of endo, right?
Okay.
So when I have a patient come in with me, and if, say, the patient has been referred for painful bladder, right? She went to her urologist and say, oh, whenever I pee, I have this pain and it hurts when my bladder is full. And the urologist sends her to me for painful bladder syndrome. So I bring out my pelvis and I say, hey, your bladder sits right here in front of the uterus, and there's a rectum and everything is connected, and there's all these pelvic floor muscles affecting it. So I'm going to ask you questions about all these systems. And then once you establish that rapport and trust with the patients asking, yeah, actually I do have pain with sex too. I was hesitant. I didn't know if it was like if I should say something, right? And this, oh yeah, I also have, this bloating and cramping. So the more information you start getting, then you understand. So our role is sometimes diagnostic in nature. So that is one role of pelvic floor physical therapy, right? The other thing I wanted to say is the sexual response cycle is always messed up, because when you have endometriosis, the endo really likes to live. I'm just going to take my organs out. So I'm going to take out the rectum and the vagina. So the endo really likes to live in this little space here where my finger is. It's called the cul-de-sac, or the rectovaginal pouch. Okay. So what happens is when someone has intercourse, and this is the vagina and there's penetration, when that force hits back here, they have a lot of pain. And when you have pain, your body sees it as a threat. So it produces less lubrication. The muscles begin to tighten up, and the sexual response cycle is all messed up. The more you have vaginismus and muscle spasm, the more your body sees it as a threat. So the pain gets worse over time, and the lubrication gets less over time, right? So this is a big, big factor that women never talk about. Like, I have pain inside. Over time, it becomes superficial because now the dryness affects it. So the sexual response cycle is a big part of the picture, and it's kind of a taboo topic. People don't talk about it, so it's often missed. So that is one role, right? So when I have someone like this, I say, hey, I think you should, maybe talk to your doctor about all these other things you have going on. It looks like there's more than just a painful bladder in your case. So
Right.
that's one thing we do. The second thing we do is, and here's where it gets a little tricky. Say someone has already been diagnosed with endo and they're sent to us, right? The doctor says, oh, she has endo. Can you help her with the pain? And I'll talk a little later about all the techniques we use, but this is kind of that strange thing that we have to do as pelvic floor PT, where you really want to advocate for your patients, but you also don't want to be stepping on anyone's toes. Sometimes the patients are sent to us with the diagnosis of endo with no other plan, like, okay, have PT, like what else are you doing for this patient, right? What about excision surgery? Did you do histopathology? Did you see how far the endo has advanced? There are patients who come to us with say, yeah, they did like a laparoscopy and I have the results, and you open up the notes and all they did was they went in and took out one little tissue and did a biopsy and say, yeah, it's endo, and then closed it up and sent it back. So how does that help, right? You're not
Right.
addressing
Correct.
the cause. In this case, our role is to educate the patient, right? You educate the patient, you provide them the right reference. Okay, so this is what endo is. This is where you need to go because these are the providers that provide you, the correct diagnosis, and they'll tell you what to do, where to go for surgery. And the last role is coordinating care with other providers. So we'll send them to a nutritionist because they need an anti-inflammatory diet. We
Mm-hmm.
send them to a sex therapist for their sexual dysfunction. We might send them to a mental health provider because, some women have been
Right.
with this for 10 years, like 15
Correct.
years, right? They've been dismissed. So there's medical trauma. So that
Absolutely.
needs to be addressed. We might send them to the excision surgeon, like I said. So that's them. And ultimately, we treat patients after their endosurgery to help loosen up the tissue, to
Ah,
downtrain the nervous system, to make sure that there's no scarring or adhesions that happen post surgery. And treatment wise, like what we actually do in treatments, the first thing we have to do is address the central nervous system to get the pain generators, down train them, which involves a lot of breathing exercises, a lot of
mhm.
mindfulness, meditation exercises. Down regulation also involves vagus nerve training. So there's different strategies that we can use to get the vagus nerve addressed. We do visceral mobilization, where we are sliding and gliding the tissue along the abdomen to make sure
Mhm.
that there's no scar tissue, no endotissue stuck in between organs,
Ah,
right? We also have to address the orthopedics. So we address hip mobility, spine mobility, diaphragm, rib mobility, all of that. Uh, like I said, some women have been put on birth control for a long time, and some of these women have been in an induced menopausal state, which affects their bone density. If we know that the patient has been through this, then tons of weight bearing exercises to improve bone health, right? So that's an important component. And then finally, we do manual therapy to the pelvic floor muscles. So we go vaginally into the muscles and we kind of work on the muscles to get them
okay.
to relax. We can use our fingers. Usually we go in through the finger, or we can use dilators, wands, things like that. We teach patients how to use these things themselves, so they have a home exercise program they can follow through.
Awesome.
Yeah.
Yeah. Wow.
So
Wow. That is incredible. That is a big learning for me as well, Tanvi, because there are so many things, like you said, it's not just Kegel's exercise. It's like endo is complex. There are so many things going on. So we definitely need a teamwork handling those clients, right? I remember an endo client I saw last year, and she came with her mom, and she was just for first 15 minutes she was just crying because
yeah.
she's like, I don't know how I can manage this condition. So I obviously sent her to a pelvic floor PT. I was working with her, providing her the anti-inflammatory approach, because there is so much, it's complex. So food from every area where we can help her. And she was also working with a mental health specialist because she needed that so badly. So I'm so glad you touched upon every area, because it has to be teamwork, because they are not going to get relief unless you do that. And just you briefly touched upon the treatment options. So those techniques are awesome. But can you also talk a little bit about the surgery that you just mentioned a little bit more, so that people know where to look for
Yeah.
and what area to go? Because there is not always a clear answer
Correct.
available.
Yeah, and this is, I think, a very important point, because a lot of surgeons do surgery, but not every endosurgery is the same surgery.
Right.
Endometrial tissue sometimes goes so deep into the system. So there's two kinds of surgeries that surgeons do. One is called an ablation surgery, and other
Okay.
is excision surgery. When they do ablation surgery, they just buzz off the top, just kind of burn off the top tissue. But that's like removing the tip of the iceberg, because then you have this whole iceberg underneath that will just kind of keep generating the pain.
Mm-hmm.
An excision surgeon is a deeper surgery. An excision surgeon is a more skilled, more extensive, more involved surgery. It needs a lot of training. It needs a special skill set, and not every surgeon does excision surgery. When they do an excision surgery, and this is interesting, and I know that was not your question, but I just want to bring this one thing up. I actually want to bring two things up. So
Sure.
one is, how patients get birth control pills thrown at them. I was listening to a podcast by one of the excision surgeons, and she said that America is the only country in the whole world where endo is managed by birth control pills. No other country in the world does this, like not a single other country. Why is that? Because we have this huge pharmaceutical lobby, like companies lobbying for these drugs to be thrown at patients. And so birth control pills are not the answer. I just want to put it out there. Not the answer.
Yes. Thank you for clarifying that, because yes, I would have completely missed, because that is so widely practiced. Birth control pills are not a solution for everything, and especially endometriosis.
Yeah, can they help modulate pain a little bit? Yes, here and there. Yes, because
Correct.
it is hormonal, right, at the end of the day. But it's like putting a Band-Aid on your wound. It's not going to solve. Right?
It's not a solution.
Right. And the other thing is, like the two surgeries I mentioned, excision and ablation. So both surgeries are reimbursed equally by insurance. So if a surgeon does a 40-minute ablation surgery versus someone doing, say, 4-hour extensive excision surgery, which requires so much skill and so much training and so much time and effort, they will both get reimbursed the exact same amount, whether you do 40 minutes or 4 hours. Right?
What?
So surgeons don't bother doing the excision, like it's not worth it for them, right?
Oh, God.
So we see so many ablation surgeries, and ablation surgeries are because they're just buzzing off the top. The pain's going to come back. So people have like 4, 5, 10, 12 surgeries. They keep having surgery after surgery, and the tissue keeps growing back because they did not take it out to the root. So speaking of resources, there are so many. There's a resource called Nancy's Nook. There's another one called icarebetter.com. There's Endo Warriors. These are great resources where you can find credible surgeons who are skilled in practice. These websites also have other healthcare providers who work specially with endo patients. That includes like physical therapists, occupational therapists, nutritionists, mental health providers, and of course, physicians and surgeons. So you have this whole team of expert people who know what endo is, how to diagnose it, how to treat it, and excision surgeons who are experienced to do that. So these are the resources that I guide patients to. I also have a very good network of doctors that I know who do this, and we just go back and forth. I get a lot of endo referrals from them, and if I have a patient who I think is endo, I guide them towards these people. So
wow, those would be valuable resources, and I'll share it in the comment section, so that way people know where to go for. And can you also share how can people find a pelvic floor PT in your area? You are in Brockton, Massachusetts, so for our listeners who are in that area, absolutely you are a go-to resource. but if they are in other areas, what should they be looking for?
So we have a community called pelvicrehab.com.
Okay.
So if you go on that website and you put in the zip code or your city or town name, or you put up the name of the clinician you're looking for, then it will guide you to that resource.
Awesome.
And if you're looking for something endo-specific, then as I said, we have icarebetter.com and Nancy's Nook, which are great resources.
Okay, awesome. So will you be able to send me those websites so that I can put it in the resource section?
Yep.
Awesome. Yeah, that would really be valuable, because otherwise people are just going around in that vicious cycle, not getting out of that vicious cycle. Now I can relate, like, why so many of my endo clients, they would have so many multiple surgeries because they are just removing a little bit. Again, we are in this complex insurance world where things work they have it under control, so things work the way they want to, but
right. And which is where we need to step up, right? This is our role. We need to be like strong advocates for our patients, stand up. If a provider is not giving the right treatment, say, hey, I don't think, this is the evidence, and I don't think ablation is the answer, and this patient deserves better. So yeah, definitely.
Just being informed is really helpful just to get out of this vicious cycle. Absolutely. Wow, that was incredible. Thank you so much for sharing all this information, Tanvi, because otherwise it would just be with you. But now we are able to reach so many people with this less known topic and less known solution, because otherwise it's just a band-aid on top, which we don't want.
Yeah, and I could go on and on about endo all day. Unfortunately, we don't have time, so just kind of touch the surface. If you ever want to talk about endo, just bring me. I'm here for you.
No, in future I want to ping you for another less discussed topics like this, and that way we can shed more light on that topic. So I'm gonna invite you in future, but thank you again so much for sharing all this. And so women in pain, listen up, and hopefully you get some answers and you have some informed decision making today that Tanvi just shared. Thank you, Tanvi.
Thank you, Niti. Bye.
Bye-bye.